Right, so we're going to start tonight's webinar. It's Emily Kirkpatrick here, one of the SA Health GP Liaison team members. I just want to check that everyone can hear us before we start. If I could just have a little yes in the chat box, that would be fantastic. Fabulous, thank you so much. So here we are again, another week's gone by. So we've got a fantastic collaborative group here tonight. And before we commence, I'd just like to acknowledge the land of the traditional owners on which we're meeting, and wherever you're meeting tonight, if you're calling in nationally or from South Australia. So for here, we're at the AMA SA offices, and we are practicing social distancing here tonight as well. And we'd like to acknowledge the land of the Kaurna people on which we're meeting here, and acknowledge the elders past and present. And we thank them for everything they've done to care for the land before us. So we'll commence tonight. So you can see on the list there, we've got a lot of people here who are collaborating and coming together. We've got Adelaide PHN, Country SA PHN, SA Pathology. We've got Dr. Tom Dodd back tonight. We've got CDCB with Dr. Louise Flood, the director there. We've got the SA Health GP Liaison team, myself and Dr. Danny Burns here tonight as well. And we've got the RACGP SA&NT faculty, myself as Deputy Chair, and Dr. Chris Moy, AMA SA President. And we've also got, we're very excited to have here tonight, Dr. Jenny Gould, who is the clinical lead for the GP assessment team for COVID-19 positive patients in the community. And we've also got with us as well in the room the CEO of AMA SA, and also, very importantly, to thank Adelaide PHN for hosting tonight and hosting the platform with us. We've got Crystal Myers, who is the practice support person with Adelaide PHN. So thank you so much. What we'll do is we'll commence, and then we'll really try and focus in with lots of questions as we go through this evening. So I'll hand over to Louise first.
Okay, thank you everyone for joining us again. I am just really providing a bit of an epidemiology update. I assume everyone already knows about COVID because it has been going on for a while now. So this data is as of yesterday. So globally, close to 800,000 cases, close to 3,800 deaths, and 78% of those deaths have been from those countries: Italy, mainland China, Spain, France and Iran. The case fatality rate is approximately 4.8%. This is just a map of the cases and where they are occurring, and you can see we have a larger number of cases, and this is by cases, number of cases, not by rates. So we have a larger number of cases occurring in the United States of America and in some countries in Europe. And this is always, as I've said multiple times on these teleconferences, is always going to be affected by testing practices in a particular country. Looking at the epidemic curve, you can see that initially we had a lot of cases occurring in China, and now we've had an increase globally with large numbers of cases occurring in Europe and in the Americas. These are the cases in Australia as of yesterday. You can see there have been 4,500 cases with 19 deaths. Still, most of those cases are overseas acquired, but there are still a reasonable proportion are occurring are locally acquired from a known contact, and some also from locally acquired with a contact not identified. And there is some variation across states, compared with the population. So SA, we've got more cases than you would expect compared with our population, but we believe that is testing related rather than us having more higher rates. Looking also just the deaths that have occurred. So we've got the deaths have occurred primarily in the bigger states. So just an epidemic curve there of the cases, and you can see a large proportion have occurred in New South Wales. You would expect larger proportion to occur there given the population size. Victoria has less than you would expect for their size, but that may be testing related. This is just the cases that we've had confirmed in South Australia, and this is as of yesterday. As of yesterday, we had 337, and that had still a large proportion of our cases are overseas acquired. And then second with that, we have numbers that are locally acquired with 61 as of yesterday, and under investigation. So yet to determine where those people will lie. And we are always investigating cases. So we might have one that's we haven't identified a leak, and then we'll interview someone else and then find that that person is linked to that person. And so then it does change as we get more information. We haven't had any deaths in South Australia yet related to COVID that we're aware of. This is an epidemic curve of the cases in South Australia. So this is classified by the type of case, so such as overseas acquired, locally acquired with an unknown epidemiological link, and local acquired as a close contact of a confirmed case, and then the number under investigation. So this will change as we get more cases. We'll expect that those the ones on the right will increase as we get more cases, because we don't have a full week there. But still, the large proportion of the cases are overseas acquired. Just looking by age and sex, we do have a large portion, well, they're occurring across all age groups, really, but a big peak in the older people, and I think this is primarily related to the age of the people that may choose to take cruises.
Yes.
Is probably probably what that's about. So just moving on a bit to the testing criteria, which has changed again since our last last meeting. So still the incubation period is thought to be up to 14 days, with the average of sort of 5 or 6 days, can be as short as 1 day. So if you have someone who in the 14 days before their illness, they're a close contact with a known case, or they're an international traveller, or they've been on a cruise ship, or they've been interstate. And now the new ones we've added are people who have been in the Barossa region, so in Tanunda, Noorpa, Lindop, Williamstown and Angaston, or in the regions right near those towns. And the one that we've added today is people who have worked or visited Adelaide Airport. So if you've got someone who has one of those epidemiological links, and then they also have clinical criteria. So if they've just been to one of those places but they're asymptomatic, we're not recommending testing. But if they also have been in one of those places and then also have clinical criteria, then we would recommend testing. And that clinical criteria is a fever or a history of fever. So a fever of 38 and above, a history of fever such as waking up with night sweats or something like that, or they have an acute respiratory infection. So something that symptoms are such that you think they've got an acute infection rather than some other cause for their respiratory illness. Then the next group, when we have 2 or more cases of a COVID-compatible illness occurring in a higher risk setting. So that's aged care, military operational settings, boarding schools, correctional facilities, detention settings, and Aboriginal, rural and remote communities. So if we've got 2 or more cases occurring there, and the compatible illness is that clinical criteria, so a fever or an acute respiratory infection. I think I'm missing something there. So we've also got the healthcare workers and aged care workers, and who, as well as they need that clinical criteria as well. Not sure what I'm missing there.
The new Adelaide Airport criteria? Is that fitting into this as well?
That's further up. I've already mentioned the Adelaide Airport.
Using the Barossa since the 14th of March.
I've already mentioned them.
Yes. So I think you've covered.
I'm not quite sure what I'm missing. I'll let you know if I remember. Okay. And then we've got our clinical criteria there, the same clinical criteria. And then we have one that's specific for hospitals, which is really if you've got someone with a fever or a history of fever and they've got an acute respiratory infection and we don't have another cause, then we would be wanting to test them as well. And just a little reminder about isolation. So we still have the requirements. So basically, if someone's come from overseas, they need to be isolated for 14 days from departure. If they have had not been in used adequate PPE and they're a close contact, they need to be isolated for 14 days since that exposure. And the reason we're saying if that's just so a healthcare worker who's been exposed to someone but they did have appropriate PPE doesn't need to be isolated. It's only if they have that not incomplete PPE. I've just found my notes. I don't know what was missing there. I think I've covered all the groups I was meant to cover in the testing. Then there's people who have travelled from interstate. They need to be isolated if they came from the 24th of March. And then the criteria of being isolation, also those, if you've got anyone you're testing specifically for COVID, they need to be isolated while they're waiting the results. So if those results come back negative and they don't fit in one of those other isolation criteria and you don't think they need retesting, then that person can be released. We wouldn't routinely recommend retesting, or if you've got a negative test, it would have to be quite unusual circumstances to think that a second test was required. So isolation, just a reminder, means stay at home. Only people who usually live in that home should be there. There shouldn't be any visitors, and in the home you should practice social distancing. If someone needs to leave that home, and it should only be for emergency purposes, they should be wearing a mask. And if you are isolating them because of for testing purposes, as in just because they have symptoms and you're testing them and they don't need to be isolated for other reasons, it's imperative that you let them know their results so they know they can be released from isolation. And we do have there is a fact sheet available about it. It is now a notifiable condition. It has been for a few months now, and it can be notified online. And just a reminder of wash, wipe, cover being really important to stop this spread of this infection. And that's
fantastic. Thanks, Louise. So we've had a few questions that have come through, and I'll just ask you if that's all right, if you don't mind. So particularly we've had ones around the Barossa and what that means for people who perhaps live in the Barossa. Perhaps they're a healthcare worker who's then coming down from the Barossa and working, say, in a GP clinic down in Gawler or in the Elizabeth area. Are those people required to self-isolate for any reason because they've been in the Barossa during that time period?
No, so we're only recommending isolation if you become unwell. That is really a recommendation regarding encouraging testing so that we can pick up if any close contacts have been missed or if we're getting transmissions that we weren't expecting. Some of the places these people have visited, they don't give a list of sometimes it's hard to determine exactly who is at risk, and so that's why we're wanting to widen that testing so that we pick up any cases that we don't already know about. But there's no there's no need to isolate if you're well, quarantine if you're well. If you're unwell, isolate and get tested.
And do you expect that criteria will change anytime soon to undertake more widespread community testing, since we've seen the Adelaide Airport cluster over the last day?
So the criteria for testing is frequently changing, as you would tell. We changed it on Sunday with Barossa, now we changed at Adelaide Airport today. We're always looking at where our cases are coming. We're looking at what's happening nationally, but we do also need to bear in mind laboratory capacity and testing reagents and that sort of thing to make sure that we get that right balance of picking up those cases, but making sure we have that capacity in the lab's ability to do the testing.
Perfect. Thank you, Louise. Sorry, you had one more slide left. I've just realised. Did you?
Mm-hmm.
No, I think that was it. Just that. Oh, yeah, that one.
Wonderful.
To show that.
So what we'll do now, I'll just pass over to Dr. Tom Dodd, who is the Clinical Services Director of SA Pathology, and he's just going to run us through around some of the statistics, and then we might have a bit of a chat about testing, because we've had a lot of questions already come through about the testing and what SA Pathology is up to in that space.
Sure. Good evening, everyone. So just a quick update on where we are in terms of laboratory practice and our role in specimen collection. So we've opened a drive-through collection point at the Tanunda Hospital in concert with the team up in Tanunda, and there'll be more information going out about that tomorrow. We saw about 50 patients or so come through there today, but we'll make that more widely known tomorrow. So just in terms of what's happening in the numbers of tests coming through the lab, at the bottom of the screen you can see a graph of tests per day, and we sort of hit a high watermark of around 1,600 last week, and then it's maintained that sort of level. What's quite evident over the weekend is a reduction in numbers of tests, which is actually a testament to the amount of work that GPs are doing, because about 50% of the work coming in is from the community. So there's I guess a decrease in the number of specimens being submitted, because general practices tend to be, I guess, not open so much on Sundays, and so hence that accounts for that dip. That's the residual work coming out of the COVID hospital clinics. Back up to 1,500 yesterday, and I expect that to go significantly beyond that. In terms of our testing capability, we have had one platform based around one Roche sort of set of reagents to this point. We'll have a second Roche, but an alternate platform up and running very soon, and then I'm expecting reagents for a third platform by the end of the week. So our testing capability will be significantly increased, and we feel that we will comfortably be able to do more than 2,000 tests a day. The next table just shows you how we're travelling in terms of testing across the population in South Australia. So I think it's very impressive now. We're at 15,000 people tested per million of the population, which is about 1.5 times where the rest of the country is sitting, and then you can see below that various countries right down to the United States, which is still very much playing catch up. We know the parlor situation they're rapidly moving towards, and it's a reflection of the way they were slow in getting off with broad community testing. So at least in part, I think we have a very good grasp about what's happening out in our broader community, and I think that's a reflection of the way we started testing broadly early, right from February onwards. We've been working very hard to optimise the process in the laboratory, and the turnaround time for the 1,500 cases we did yesterday was 17 hours, which is an incredible effort from the virology staff. I'm very proud of them. One of the issues for you folks in particular is we think booking the drive-through is better in terms of flow, but it's unacceptable for you folks to have to wait on the phone. So I've put on a whole lot more staff to answer those calls, and I'm told we were down to just a few minutes today. And so I'm very determined to make that work well, otherwise it just doesn't work for you folks in general practice. Domiciliary services are going to become increasingly important for patients in nursing homes, and so we anticipate taking on a much larger number of nursing staff to be able to do that on a much wider scale. And once we've got that in place over the next few days, then we think there will not be a need for the CB approval, but we'll be able to take bookings directly and have domiciliary nurses go directly to nursing homes. And so we think that'll work much more efficiently for all of you. And the other thing we are endeavouring to do as quickly as possible, we're not quite there yet, is to have a system for automatically SMSing negative results to patients' mobile phone numbers. So Ernst & Young are helping us develop a sort of a robotic system that goes in and picks the negative result, matches it up with the patient's mobile and sends out a negative result. I'm told by the IT boffins we're probably 2 to 3 weeks away from that. The sooner that happens, the better, because there's an awful lot of negative results that need to be communicated through. So I'm conscious of that.
At the moment, my understanding, immediate upload to My Health Record with a negative result, is that?
Yeah, so the negative results are going to all the ways they usually get communicated out, My Health Record, and sort of the EDI feeds to your practices.
And the 7-day limit's been removed, so those results should be viewable by the patient as well.
Yes.
So sometimes when the patient needs to have this result before they give it to somebody, for God's sakes, get them to look it up themselves.
Yeah, I know I've had a number of people call me because they haven't got their result from 3 days ago, and I know perfectly well that it's available. Yeah, all the usual ways of getting your results are there, but the sooner we can get this automated system up, the better. I understand that. Yep.
Thanks so much, Tom. We've had a number of questions that come through around testing. So we've first of all had a comment around Wallaroo Hospital. GPs or someone has commented around it being full for next week. What's the capacity of SA pathology in terms of being able to increase some of the capacity in rural areas when those services are quite heavily booked out?
So in terms of specimen collection, in the rural sites, that's really down to the local health networks having their COVID clinics in those hospitals. What we've done to assist, particularly in Barossa, because of the issue there, we've set up this drive-through specifically to assist with patients in that area. But each of the LHNs in the regional sites have set up their own COVID clinics. That's not, we don't have the capacity to do that in each of the rural centres.
So, Tom, can I ask, the COVID testing clinics run by the LHNs, the patient lines up and lines up and lines up and gets to the front of the queue and asks some questions, and often they're turned away because they don't meet the criteria. That's fine, and then the ones that do meet the criteria get tested. Whereas your drive-through clinics, SA Pathology, they rely on the patient having a SA Pathology request form from a GP, and you won't turn anyone.
No, so the clinical assessment's effectively been done by you folks as the clinician, considering the epidemiological criteria for testing, and if you judge that the patient needs a test for whatever reason, whether it fits perfectly within the criteria or for another clinical reason that you have assessed, we will swap them.
Mobile phone, put it on there.
You definitely have to have a mobile phone number.
on there.
But very important to put the mobile phone number for both yourself and for the patient on the request form. And
on that request form, you want us to request respiratory, PCR and COVID?
Yes, please.
Yeah, not just COVID.
Yes.
Yeah.
And something that has come up here on the questions is around, are GPs ordering tests, when they don't meet the criteria, but ordering respiratory panel tests and getting that added in COVID? So a couple of people have made comments around that. Is that still a way that GPs are using to sort of bypass that criteria?
My assessment of the situation is vastly now the tests are based around the COVID testing criteria as defined by the CDCP. We've added in the additional viral screen for influenza and a number of other viruses. Doing that does not consume any more reagent than just doing COVID alone, because you have to do that extraction step before you test for influenza and COVID. So whether we add the extra viruses in or not doesn't consume any more reagent than if we just did COVID alone. So that's not an issue in itself. But obviously at the moment we're targeting particularly COVID patients or people that you deem should be tested specifically for COVID.
Actually, can I just say, I understand you've changed what's in the panel compared with what you had last week, because I know last week I was saying if you thought someone had pertussis, you had to ask that specifically, but I understand that's now in the panel.
So yes, that's right. We've been optimising, so pertussis is back in the panel. We've dropped rhinovirus to make space for it.
Fantastic. Another question has come around about false negatives. couple of people have quoted this statistic around 30% being false negatives. We've had a couple of people post that in the Q&A. So I just wanted to ask you, is there any data around false negatives with the current testing that we're doing?
So the testing platform is highly sensitive and specific. I would suggest that if we're getting good samples and the patient's positive, we will turn a positive result false. It will come down to whether or not, I suppose, we are swabbing patients at the right phase. If we're swabbing asymptomatic patients, there will be a risk, of course, that they're not shedding virus for detection, and that might account for some of the false negatives. So, as we've said all the way along, they've got to have epidemiological criteria and be unwell.
And another question we've had is around point of care testing.
Yeah.
Is that something that SA Pathology is looking at, or is that something we can see in the future?
Yeah, so there are two parts of this. There is going to be very soon a rapid point of care test for viral RNA. That will be available in each of the regional laboratories to support the regional clinicians and patients. It will also be available in all of the metro hospitals. So that provides a result in 60 minutes and will be very important for triage in the metropolitan hospitals, and also to support rapid decision making out in the regional areas. Currently, many of you would be aware that there are finger prick blood tests being promulgated. That's a serological test, and at this time it has no place at all in the pandemic in Australia. So the issue with that is it detects obviously antibodies, and there is a significant lag of days between the time that a patient becomes infected and will be contagious for antibodies are produced. So you will have a window where you would have a false negative result. The other thing is, of course, this is a coronavirus. There are lots of other coronaviruses, and there could well be cross-reaction and therefore false positive results. Serological testing will become important to establish past infection in asymptomatic or minimally symptomatic patients, and we will introduce that once we have a very reliable and specific test a little way down the track. But at where we are at the moment in terms of the pandemic in Australia, this does not have a place right now, and that's a uniform view amongst infectious diseases physicians, pathologists, and the Royal College of Pathologists of Australasia have put out a definitive statement around that in the last few days.
And something that has been raised as well is around collection centres and whether patients will be able to book in for an appointment at a collection centre. So we've seen the updates come out from ClinPath that patients can book online for their appointment. Is that something that SA Pathology is looking at?
Yeah, so we're looking at a number of ways of managing that. One of the things we will set up very soon is a collection centre really specifically for patients who are vulnerable with immunosuppression and that sort of thing, to try and segregate that group of patients away from others who would have other infections, including COVID. But yeah, a booking system would be a good idea.
And I don't know if others have seen this, but I certainly saw this for the patient that I ordered a stool test on last week, that the PCR wasn't run on those patients. And then I saw your update today, Tom, that for hospital patients that they'll still happen. What about general practice?
Yeah, that's right. So what we've done in the very short term to preserve reagent, because it's exactly the same extraction reagent that's used for all infections, is to briefly pause the enteric testing. We've recommenced testing for the hospital patients, and we'll make arrangements in the next day or so how we will manage that for general practice, and we'll be communicating that out broadly to all of you.
Wonderful, thank you.
Actually, Louise, can I ask a question? It's just been something I've been pondering, that with all this social isolation and shutdown of restaurants and so, have we had an actual decrease in gastrointestinal infections like Campylobacter and so forth? Do you know if those notifications have changed?
I actually don't know. If you give me a bit, I can look at my data, but To be honest, I've been so busy with COVID, I haven't had a chance.
No, I was
to
just
look.
wondering if it was going to be sort of a positive side effect of the.
We are expecting that.
Yeah.
We're expecting to get. I mean, we know there's been other respiratory infections seem to be around.
Yep.
And we are expecting it to decrease.
And
the jury's out a bit on what's going to happen with STIs, I have to say. People aren't really sure if they're going to go up or down.
Yeah.
Because, we're all meant to be in one,
Yeah.
I
think there's going to be a lot of babies born on Christmas Day, if you ask me.
But I'll have a look, see if I can get that.
But also because there's so much hand washing.
Yeah.
I mean, I've never washed my hands so much in my life.
Oh dear. And just one other thing as well, Tom, I was going to ask you was you put out a release around self-collected swabs.
Oh, yes.
And we sent that out to GPs around not performing self-collected swabs. And then we've got Norman Swan, who's declared that he's self-collected his swab. So just wondering, are you able to provide a little bit of elaboration on that? Was that because of poor technique of the patient performing that themselves and the unreliability with that, or what was the basis for that message of not using self-collected swabs?
So I suppose if you're a physician taking your own swab, you can be pretty confident you've done it well. There are a couple of things, isn't it? It's about sampling. We're talking about false negatives, so it has to be a proper sample from the posterior oropharynx and the nasal cavity. And so we want to be confident that we've got a good sample from the patient, because that will be a potential source of false negatives. And the other thing is, of course, it's about handling and packaging, because obviously the specimen has to be packaged up in a way that that ensures there is not transmission of virus onto the surface of the container and then onto the bag and so forth. And you might be quite surprised the number of different sorts of samples we've had come in that probably don't really meet good handling technique in terms of hygiene. So that's another concern. Obviously, we don't want to transmit virus to health workers, and I don't want to bring down the entire virology lab because there's a virus on the external surface of a package.
I just might answer, it's Louise again, I might just answer Danny's question. So so far this year, Campylobacter, we've had, this was up until the 28th of March, we've had 654 cases compared with 860 at the same time last year and 733 at the same time the year before and 925 at the same time the year before. So from Campylobacter, yes, it is
definitely down.
Definitely lower than we had at the same time. Salmonella, with the change in testing, just briefly, it's a bit harder to determine, but those numbers are, again, a lot lower than we've had in previous years. So, yes, looks like it is paying off, and we just have to see if we can sustain that when this is all over and everyone is used to washing their hands.
Louise, can I ask you one other question which has been brought up? Because I'm just looking at this stuff from King's College London about the smell taste issue, which is, I mean, they've actually indicated here in their data that shows that it's a loss of taste and smell may be a higher predictor than self-reported fever as a potential clinical thing. I'd be interested to see whether this actually turns live, but has there been any thought about this as being a potential?
I did get someone to, I think last time mentioned that they were doing a bit of a literature review about it, and there just really isn't sufficient data to comment on it, whether or not
this has just come off, you might not have seen this actually, but this is hot off the press.
But I mean, I think you need multiple studies to really show if it actually is true or not.
Great.
Tom, can I ask you, which is really, I think, hammering the same point about the false negatives, but what GPs ask me and patients when I call them is, you know, a family of 4 got off the same cruise ship and 3 will test positive and 1's negative, but they've all got the same symptoms. So it just seems logical that the 4 would have it. And there's been other cases where they've been symptomatic, they test, it's negative, and the symptoms persist, and 2 days later they retest and they're positive. So I guess that's made people a bit uncertain about feeling confident about the negative result.
Yeah, so I think like all laboratory tests, clinical context is incredibly important for interpretation. And so the sort of scenario you've described with 3 people off a cruise ship all cohabiting in a cabin together and 3 are positive, 1's not, they all have the same symptoms. Yeah, but basically on clinical grounds, you'd have to assume they're all positive. Sampling will be very important. If there's viral particles in the sample, the test is a PCR amplification test. It's incredibly sensitive.
Yeah. So yes, clinically if you suspect it, and it's also probably more a reflection of the sample, how it's been taken rather than...
Yeah, and timing around, you know, when patients start to shed virus, I guess.
Perfect, thank you.
And talking about shedding of the virus, a couple of questions that come around about stool testing. And is there any value in sending the stool either to the lab for examination or for testing purposes or research purposes, and any evidence to suggest that there's fecal oral route spread as well with coronavirus?
Louise might like to make a comment, but we have detected the virus in faeces in patients in hospital. It would not be the standard way of testing at the moment.
So it's not thought to spread through the fecal oral route, but it's still thought to be spread through droplet and contact. But you still need to be careful with that contact route in that, you know, if you take an object, put it to your mouth and it, you know, using a spoon that someone else has used or something, even though it might be through food, you're actually putting it near your mouth. So it's, but it's not thought to spread through food as in a foodborne object type thing, like a salmonella outbreak or something like that. It's not thought to spread that way.
Fantastic. And Danny, you wanted to say something, did you?
No,
sorry.
just...
We've cut you off, Chris, from being able to start, because you've had a lot of questions come through around elective surgery and general practice clinics, and I know you're going to cover that, so we will get to that. So thank you for being patient with all your questions in the box, and thanks, Chris, as well.
No worries. Look, I'll do my usual mixed bag, so we'll just go for a whole lot of things which are hopefully practically relevant to you all. I'll point you back to the flow chart. The flow chart's still live, but we're just now linking it's now linked directly to the updating epidemiological criteria for testing now, but pretty much everything else is the same. So I'll point back to that, which leads on to Health Pathways South Australia. I'm going to keep on advertising for them because this is the place where I'm going to keep on putting all my links, and everybody else put all the links that are most useful because there's so many places to go to at the moment. So whatever I talk about today that's relevant, we'll add to links. I'll send them off to our people and we'll add the links. And Danny, you'll do the same?
I just found out today that Health Pathways are going to put all their links on the web. You won't need to add a password to get in. They just
no, you will, but it'll be if you go to Health Pathways SA, the password and the login will be a generic one, which you'll be able to go straight in from.
So it'll be there for you.
So all you need to do is actually Google Health Pathways South Australia, and you'll get there, and then in you go. Okay. So you won't have to apply for a login. Those with PIN should be able to get in there automatically anyway at the moment. Okay, NDS, telehealth, I think most of the questions are going to be about that. I probably agree. So obviously we've been working really hard on this. So frankly, to keep everybody's care for their patients going, but also to keep the lights going in many of our organisations. So the major change that occurred fundamentally was what we've been fighting for, was really a removal of all the, that's available to all Australians. So there's no more of this in the criteria. So the aim is that that you can provide this service to any patient where you do not need face-to-face, and therefore reserving face-to-face care for situations where it is required, such as when you have to lance a boil or, stitch up a laceration or something like that. So that's the idea, that's the plan, and that was always where we were advocating very hard for. You probably see the GP attendance items, but in addition to that now, there is the chronic disease management items are in. There's also the health assessment for Aboriginal and Torres Strait Islanders, but not for the over 75s at this stage. So are you having trouble hearing?
We just had a few comments that people are struggling with the audio, that's all.
Can you hear better?
Yeah, we'll see if we have some comments.
Okay.
Sorry.
So that's that's where we are with that. So we don't, now we've also got the autism management, pregnancy support, eating disorders management ones, but probably the other one, which is a biggie, is the mental health items, which are now got equivalent as well, including those for treatment, and urgent after hours. So you'll see those. The other thing that's important is that there is a practice incentive payment, and that is essentially a doubling of the, do you want to just move that one?
Yeah. I think your voice is a little bit loud. And
oh, sorry.
That's what the problem
Sorry,
is heard.
wrong problem. Yeah, no, I shout a lot. The main thing is it's a doubling of the practice incentive payment from practices which are in a position to remain open and provide face-to-face care, because so that is a benefit to practices at the moment. The other thing that keeps on coming up is just there's all these questions which keep on, the same questions keep coming up, which I'll deal with the main ones. So there is this frequently asked questions document which we'll send out, which has just been updated. There was one last week and there's another one this week. The main questions keep on coming up to consent. So the Department of Health position is that under these exceptional circumstances for the new temporary MBS telehealth items only, so all the ones that I've discussed before, the practitioner's documentation in the clinical notes of the patient's agreement to assign their benefit as full payment for the service would be sufficient. So basically you have to get verbal consent and document it in the notes, right? That's the long-winded version of saying that. The second thing is about provider numbers. So there's actually been a bit of miscommunication from the department about needing a provider number, a new provider number, when you're working from home. That is rubbish. Don't listen to any of that. Providers do not need to be in the regular rates of practice for telehealth or telephone services. Providers offer their services from home isolation or quarantine should use their provider number of their primary location. And so you do not need to apply, because some people have been told they need to, after 2 weeks, if they're working for more than 2 weeks outside of their practice, they need to apply for a new provider number. Do not listen to them. The other one is about the 12-month rule, which has been a bone of contention. The issue is about whether before it was that you had to have had a contact with face-to-face contact with that practice in the previous 12 months. Now, there's been again a little bit of confusion about this. We were initially told initially that you had to be able to provide face-to-face service an option of, but in fact, I've actually had further clarification from Federal AMA, and so this is in that document. It says all Medicare eligible Australians can receive these services. There's no 12-month, okay? So just remember that.
And Chris, any chance we'll see private billing added into that as well? We've had a few questions on that.
That is, okay, this is a secret between you and I. It's in play, we're working really hard on it, okay? So just relax. It takes a hell of a lot of work and effort to get there. Trust me. Okay, just relax. Okay, we are doing our best. We're busting our guts, and I'm not earning any income while I'm doing this for you guys, so just don't argue.
I think it is reasonable. We've said this previously, that a lot of, how many million Australians lost their jobs, been laid off. I mean, it's a bit hard to be sort of complaining about, loss of a few dollars. In the context of what the whole of Australia is going through. Yeah. So I think between doctors, it's fine, we have these discussions, but when doctors on the radio have been saying, oh, poor me, it doesn't sound so good.
Yeah, look, what I'd say is that we were always going for this from the start, but we were going really hard at this to keep your lights on, basically. Mm-hmm. So, you need to understand these things normally occur over years. This has occurred over weeks. So it's been an unbelievable effort. Okay, so the next thing is another query is always about the assignment of Medicare benefit. No, the issue is if you have a face-to-face consult and then, they have to press your ATM, the ATM machine button or the sign a form, which seems completely counterintuitive when we're trying to reduce physical contact. So this is the email I received today. The department, the problem is there is actually legislative requirements with respect to this. So it's not that easy to just say you don't have to do anything. But the workable solution, which I have received in an official email, so if ever I get into trouble, I'm going to be handing this email up from the Federal Department of Health, is that if a patient or staff member, and this is senior stuff, Department of Health, if a patient or staff member is concerned about contact with the document due to potential exposure, The practitioner should discuss the financial blah, blah, the usual stuff. But tick the box on the form that says unable to sign and giving the reason as COVID-19, highly infectious pandemic at risk of exposure to COVID-19, etc. And then you'll be audited if that doesn't happen. But that's basically, it's the unable to sign requirement under provision. So that is actually in hard copy today. So I got that clarification today for everybody, because we've had a few queries about that. Okay, this is the biggie, e-prescribing.
Chris, before we move on to e-prescribing, can we just talk just a little bit more about the numbers? Is that all right? Just while we've got lots of questions having come through on this. So after hours numbers, are we going to see a change or have those included, do you think?
There is the urgent after hours one. There is that one, bad unsociable hours time. There's the other one. The other thing is about the telehealth aged care facilities. There is not any intention at this moment in time for new item numbers for that, because they involve a call-out fee. And there's technically no call out for a telehealth item. So we've been told just get on with it and just use the current normal consultation items for aged care.
Mm. And the other thing was around, you said about the 12-month rule in terms of having seen the patient in the last 12 months and how that's not in there anymore. A few questions have come through around auditing. We've heard of some clinics have been texting patients, to have a consultation and whether that's part of increasing their business. Is there, do you think an audit would ever occur of those practices to see if they are complying? And
look, this is the problem. Everybody's wanted this 12-month off, and the reason why the 12-month was on was to try and prevent predatory type behaviour like this, which does not in fact actually show us as a profession in a very good light. And frankly, that was actually the reason why they held out on this issue. So I've had some people in one ear saying get rid of the 12 months, and the other people say, oh God, what will happen? Look, the bottom line is that there are actually medical board requirements and professional standards and AMA ethical standards with regards to advertising. And that would actually constitute basically advertising. You cannot go out there. You're not allowed to do that. You're not allowed to go out there and say how great you are, and you're not allowed to you can't use testimonials, you can't do any of that sort of stuff. That's unethical. So that's off the table. So I'm going to say flatly, if that's happening, that's actually naughty. Now, having said that, APRA have been pretty sensible and having talked with them about the way they're going to be, they understand this is actually a bit of a bun, we're doing things really hard and everything's a little bit dicey. But I would say to you, just if you're doing the right thing, you're fine. I think the day may come where those organisations may be audited, and if they have been advertising and they're found to advertising, that would still constitute inappropriate behaviour with respect to professional standards.
Thank you. And a couple of questions around co-billing as well. And if you call someone up during the in the morning, they're booking for a telehealth consult, you decide they need to come in later in the day for an examination. Say, for instance, they've got an ingrown toenail that's infected, you need them to come in and address that. The rules around co-billing those items together.
I think that would be the same thing as you have two visits that are currently, sometimes you have had a situation in the morning and you dealt with something later in the day. I think there has to be a reasonable gap and there's a separation of the actual services. But look, what you do now with two face-to-face consults is the same as a telehealth and a face-to-face consult.
Yeah, I wouldn't get too hung up on all these little what ifs and what ifs. Just use a bit of common sense.
Yeah. They're not going to look. I am not joking. I mean, this has been a really good spirit of collaboration at the federal level in the Department of Health. So cut them some slack. Usually they're tough as nails. Usually, having dealt with them before, but they've actually been really good because they understand this. But our issue will be actually inappropriate behaviour and abuse of these items, because we may lose them at the end if it's found that we've actually abused them. And look, I think just do what you're doing now and do the right thing, and I think we'll be okay. But if you are having this, if you're seeing this sort of advertising going on by pop-up clinics who are just doing telehealth, that would constitute unprofessional conduct, I think.
Hasn't there been a new ruling that you have to have your surgery available for face-to-face at least 4 hours per day?
No, that's for the practice incentive payment.
Just the practice incentive payment.
Because there are practices that won't be able to do that, because if you have a practice with, say, two doctors who are either over 70 or immunosuppressed, they wouldn't. Right. They won't be able to potentially open it at all.
Yeah. Just for the PIP.
Yeah. Right. Okay. Can I help you? Okay. The big thing this week has been e-prescribing, and frankly, it's occupied a lot of my life in the last few days and even today, as Emily and Danny have been great. We've been working together on this. The issues are there are federal and there are state jurisdictional issues which are not as easy as they sound to change. Now, I want to talk to you about what you can do now. I know people are finding this annoying, but that's just the way we've got to suck it up at the moment. So at the moment, what you can do is you create a legal paper prescription during the telehealth consultation. You can sign it, and then you either send a copy of this to the patient or the pharmacy as a fax, photo, or PDF. And then what happens then is you have to send the paper copy to the pharmacy within 15 days. Now, people are saying why you need to do that. There's two reasons. Under current PBS guidelines for federal, for the pharmacy to, if it's a PBS script, they need the original to be able to. Now, we're trying to remove the legislative requirement for that at the moment, and that's actually live. But the second reason is, and it's already happened, is people have actually faxed a script or emailed or texted a script to a patient, and they've gone to 5 pharmacies, right? So that's the reason. Now, everybody, has been really upset about it, but that's the reason, because it's actually a safety issue, and particularly given the current anti-hoarding type sort of strategies, it's not a good thing at the moment. So it's actually happened already, and that's why they won't remove that straight away. Now, we are, just to explain where we're headed. Now, I've heard on, Doctors for Doctors, if you can send this barcode, and that's enough. That is not correct. I've actually asked federally this afternoon, the meetings and at the federal level. So I'm actually leading the discussions with federal about this e-prescribing. What they've said to me is that doesn't work because it doesn't actually constitute it doesn't contain the identifiers to the patient, and it doesn't, and the pharmacy cannot actually link it. It's too hard for them to link it to patients. It doesn't link to, it's not linked to the identifiers. The other thing is that there's this other idea that maybe you could use a software program to do it, and again, you've got the problem. So at the moment, it's as what I said before, you have to send the script to the pharmacy. Now, where we are trying to get to is either a fax, email, or text of the image of the signed script to the pharmacy, with the pharmacy named on the script as dispensing pharmacy. And if we can remove the federal PBS requirement to have the script for the pharmacist to be able to get the PBS script paid for that, there will hopefully be no need for the original to be sent to the pharmacy. Or a fax, email, text image of a signed pharmacy, and the doctors to keep the copy of the original signed script for 2 years with no need of the original to be sent to pharmacy. That may not occur in South Australia because of legislative requirements. So we are trying to work our way through this. Not my fault. This is actually state and federal legislation, and it ain't easy to change. Hopefully state are going to be quite amenable to changing their component of it, and the feds are going to try and remove the PBS requirement bit at this moment in time. We're hoping we'll get some changes by the end of the week. So the interim will hopefully be that. I'll just say one more thing, Danny. Yeah. Finally, where we want is to get to ultimate is e-prescribing from clinical software. What will happen then is that you'll be able to do it from your clinical software. It'll actually have your digital signature embedded in there with the identifiers about who you are, where you came from, who the patient is, and then what will happen is it will either be sent as a barcode token to the patient, which then can take that to the practice because it will have the embedded signature in there, or to a prescription exchange service in the cloud, which the pharmacy will be a link to. So the pharmacy to practice, the patient can turn up to any pharmacy and they'll turn up and they'll be able to show their Medicare card and some ID, and they'll be able to get their prescription. But that's where we're going to get to. But there are some technical issues at the moment, which this project was actually in line. I was actually technically on the team that was supposed to be developing this early on, but I've actually been taken off it for doing all this other stuff and more the legislative stuff. But that is still going to take probably a couple of months probably to get done. So in the meantime, you now know what you have to do. You have to send a script. We're trying to get to the interim, and then hopefully we'll finally get to this seamless. Danny, you can ask a question.
So this is breaking news from Naomi Burgess, who's the chief pharmacist. This is current legislation, which I have to say I never knew. But if you fax a script with the name and address of the pharmacy, and you fax it to the pharmacy, you do not have to follow up with the hard copy original at all. But you have to
fax it.
Fax it.
And it's not a not a text.
Not a text.
It's not a. It's a fax.
Email. It has to be a fax.
And it's not e-fax.
No,
apparently.
it can be. No, it's e-fax.
E-fax is allowed.
I think that's what she said in the email, didn't she?
It's up to the minister to grant an exemption. And there are options in the legislation for the minister to grant an exemption.
But does that remove the PBS? Have they,
No.
No, see, the problem is at the moment, you still, no, stick with number one until we sort this out.
Yeah.
Do not listen, no, understand that's where we want to get to. That's what the discussions were. We've had a couple of meetings today about this already. That's where we want to get to.
State legislation.
Yeah. There's the state requirement, but the pharmacists are not going to cope with it because they won't get their PBS. Okay, so at the moment you still have to send it. Sorry about that, but that's just the way it is. It ain't that easy. We're trying.
Yeah.
Okay, so just briefly, driving assessments. For those who weren't on the line last week, you do not have to do the routine medicals, the over 70s, the routine thing. For God's sakes, don't do them. Tell your patients not to do them. I don't know. I've still got some queries afterwards. You don't. You do not have to do it, but the other thing is that if a patient's suspended, you have to actually, they stay suspended, unfortunately, until we sort it out. That's the table. The next thing is Return to Work SA. A lot of queries about Return to Work SA. They've been fantastic. So Department of Health have been fantastic. Return to Work SA have been fantastic. Please go to their website. This is the website. They've actually got great information about that at the moment. Okay, so everything's switched to telehealth, basically, if it can be done by telehealth. Personal protection supply, I told you last week, if you've got it, secure it. Cancellation of non-urgent surgery. So as of last night, there was the implementation of new legislation, which is the Emergency Management Appropriate Surgery During COVID-19 Pandemic Direction. This basically requires that only surgical treatment that can be performed in the state of South Australia is emergency surgery and procedures performed conditions which are failure to do so expediently and safely will lead to the following outcomes: either loss of life, loss of limb or permanent disability, and in a non-emergency situation, performed for conditions where failure to do so in a clinically appropriate time frame within 30 days will lead to predictable and evidence-based outcomes such as loss of life where surgery or procedure would otherwise have prevented, permanent disability where surgery or procedure would otherwise have prevented this, or clinical evidence supports increased risk of a type referred to subparagraph. Now, and provided that no alternative non-surgical procedural intervention exists. The procedures may, for example, include endoscopy, bronchoscopy, interventional radiology and cardiology. Now, look, there's been a lot of an uproar today because I think the issues have been related to the grey zone with regards to this. Okay, there was one text from the police which was a bit over the top, but just ignore that. They just went a bit overboard like they normally do with their wording. But basically, this is legislation, so you basically have to stop non-urgent surgery. Now, the question's got to have been asked, for example, though, what happens, and I'll give you some examples from other areas. What happens if I've got a person who needs urgent cataract surgery because they're diabetic and they can't see their pen? Well, that would fall in this. If a patient has a malignant melanoma or likely melanoma, that comes out. A BCC on the thigh, probably not. But a BCC which is sitting on the facial nerve or something like that needs to move, or near the eye orbit that needs to move because of risk of deeper damage, well, that would probably fit. So there is actually shades of grey. Now, I spoke to Chris McGowan today. This is not a witch hunt to find, to stop everybody. What they're trying to do is stop really inappropriate low-level surgery which shouldn't be happening. And that does include cosmetic, I'm afraid. That's out of play. So, I mean, if it's a cosmetic surgery and somebody's chugging on with that, they are going to get caught. But there are going to be these grey areas. I've looked to the colleges at the moment, and I'm not a college, so I can say to you that the problem is there's so many grey areas. There'll be some guidance hopefully coming out of SA Health very soon. I'll hand over to Emily for a second to talk to this.
I was just going to talk. We had a couple of people contact us today around IUD insertions, and certainly contraception fits within required medical care, and that is not classified as a surgical procedure. So that is okay to continue. So we have had a few questions come in here about that tonight as well.
Yeah. Again, I think there's a level of common sense here that requires, and you're not going to get strung up for doing something that's clinically appropriate and does have some urgency to it. I think the issue will be if you're doing stuff that is clearly not, and I think that's what. And Chris has said that they're not going to be going out for everybody. Okay, they're going to go for people that are doing inappropriate stuff.
Well, the purpose of the legislation is to free up beds and ventilators. That's
and PPE.
And PPE, yeah. So.
And can I just add there, so there was a lot of questions today for me around elective caesarean section and termination of pregnancy and and yes, the clarification is that they are appropriate.
And just while we just had Jenny talking then, so just to introduce Jenny's role, so Dr. Jenny Gould is the clinical lead for the GP assessment team as part of community positive patients. So Jenny's going to talk a little bit about what that means in terms of managing patients in the community, and then we'll talk through that with Louise a little bit about what happens at the end of that process. So I don't want to cut you off,
No,
Chris,
nearly
but
finished.
I thought I would just introduce you because you spoke about it.
Nearly finished. I'm going to nag you about My Health Record again because this is the time to do it, because if we do My Health Record, it's going to be really very useful for other people down the line, given the fact we can't actually, it's very much harder to transfer files at the moment. So please consider uploading stuff to My Health Record, and advanced care directors, if patients can scan those and upload them, that'd be helpful. It's not that easy, I know, but it's a good idea. There's some guidance for certifying deaths due to COVID-19. I'll put it up on the site. The Health Pathways site. So there's Australian Bureau of Statistics have actually given some guidance about this, and the main thing is that you need to put it on there as COVID-19 if you think it is, because we need to be monitoring what it looks like. So I won't go into the detail. The other advice we've had is that David Holden from the Palliative Care Clinical Network has received a clarification about, does a telehealth consult with regards to a patient constitute care that therefore you can actually then write the death certificate? And the answer is yes. So if you've actually carried out a telehealth consult with a patient, the issue is about whether you've seen the patient before or you were you treating them in the last illness, that the answer is yes. Good. Okay. We've had a lot of queries about this, so if you need that, just give us a query, or the PHN have also got details about the people that provide these sneeze screens. A lot of queries about that. Aged care facilities, which can I just say that I'm so worried about them. They are the single biggest, scariest place. I mean, they're basically floating, stationary cruise ships ready to get infected. They've really got paranoid and they've closed it down. Can I make a strong suggestion that you work, a lot of these facilities, and I'm working with mine, to minimise the number of times you have to go in, particularly for the normal stupid paperwork that they ask for, and they've got to find a way. So I've negotiated with mine, and we start talking about, text being a signature, the email being signature, doing stuff by email, that sort of stuff. I really would start. Our problem is that we have a lot of us, so we all do things differently, but every contact like that is actually going to be a potential risk, not only for the introducing it, and we are not God. Okay, we've had a bit of a pushback about this, that oh gosh, we're the safe ones. I think that is bullshit. Basically, we are very high risk of taking it in there and actually also getting it in those areas. I haven't been in places where they had lockdown from norovirus. Oh my God, they are just shocking. So please follow the rules and try to minimise times you have to go in there. Palliative care, 7-step pathway, I'll put it up on the website. So please do this, because if we can get the not-for-transport hospitals, for those people that don't want to go to hospital, and I know a lot of my patients don't want to, that will minimise the risk of patients, then we can actually know what to do with patients, provide palliative care for them. And I'm just going to finally advertise for the AMA. A lot of people, I'm going for this time. Yeah, Emily's had a go.
Well, I'm going to advertise for the RACGP.
Yeah, you can go. But you've got all the members. I'm an RACGP member as well. Our problem is that we're actually a voluntary organisation, and in fact, we're a non-for-profit organisation, and we don't. We actually go into bat for all of you. We have over the last few weeks. Me personally, and we would actually appreciate as many of you becoming members as possible. We actually people have actually said to us, but our incomes have dropped. But can I just say, I've actually derived no income in the last little bit doing stuff for you guys. And the thing is that the stuff we've done has actually helped keep your lights off, and me personally, in the time that I've been working. So if I could just ask you to do that, because we are much stronger. This is what we do. The AMA has always done this slowly behind the scenes. It's just this time you're seeing what actually happens in fast speed, isn't it? And Emily would understand what that means. But yeah, if you could, that'd be helpful.
I'll put my hand up and say I'm an AMA member, and I've been superbly impressed with the amount of work Chris has done. I think we should allow him that little advertisement.
I asked permission.
Yeah. It's like all these representative organisations. You're doing that work is for the benefit of all of us, and perhaps only a small number of us are actually paying. So have a think about it. Thank you.
Thanks, Chris, for that. And so, yes, the RACGP are putting out regular updates, and you're probably getting nightly emails from them as well, which also contains a lot of the information that we send out, Danny and I send out in our SA Health updates. So what I'm going to do now is just go back to what I was saying of introducing Dr. Jenny Gould, who is our clinical lead for community positive patients. And we've had a lot of questions, particularly directed to Danny, around this space in terms of, well, what does a community positive patient mean, and what do I have to do as the GP in looking after these patients? So Jenny's going to give us just a little bit of background about her role and a little bit about what it means as a GP to manage these patients in the community, and then we might have a discussion with Louise around what happens at the end of that process in relation to the song.
Thank you. Yes, so I'm Jenny Gould. For many of you will know me in my other role, which is the statewide GP obstetric shared care program, which have been the GP advisor for a long time. So this role is new. It's only been, I think, day 9 of this role. So what does it actually mean? So where do we fit in the process? So when someone is tested for COVID-19 and they get a positive result out of the fabulous SA pathology lab, so CDCB will notify them of their positive result, and at that time on the phone call they'll be advised they're going to get 2 follow-up phone calls. One will be about their contact tracing, and the other will be a clinical call to check on their wellbeing, which is where my role comes in, and the team that I oversee, which is a group of GPs that work through GenWise. So then we ring all of those COVID positive patients who are being sent home, that they're relatively well, and we have a bit of a standard template, which is really along the lines of a standard consultation, checking out their safety to be at home, assessing their ability to self-isolate, looking for comorbidities and things that would make them more at risk. And in addition, identifying anything that they might need support with, whether that be community-based around getting groceries, or they're isolated and just need support, or whether they're extremely anxious, or whether they need sort of increased medical surveillance where they can be referred to the remote surveillance unit, who can make up to 2 phone calls a day to check in on them. So we do a sort of a comprehensive assessment, if you like. We document that, and then the patient is asked about their usual GP, and we then would contact that GP via the phone and do a verbal handover. And can I make a plea at this time that can you ask your reception staff, if we get through all of your fabulous recorded COVID-19 messages that I have listened to and could almost recite word for word, that if you can possibly take our call when we ring about the COVID patients, it would be great, because we do spend a lot of time ringing back, waiting on hold. Anyway, so then we hand over the patient to the GP if they're happy to take that patient on, or if they haven't got a regular GP, or that GP is unavailable or doesn't want to take on that care, the lovely Danny Byrne will find them a willing and able GP, and then we'll connect the patient and that GP up together. So once the GP has agreed and we've had a clinical handover, then documents are sent to the GP, usually the next morning, which will have the consultation details and a number of resources that might be useful to the GP as part of that. So that's kind of our role and how that all looks. Yes, do you want me to pause there and see if there's any questions?
Well, Danny's voice.
I was just going to ask, what's it like talking to the...
Yeah.
You've done about 50.
Yeah, so
what's the range of clinical scenarios and morbidity and that, like the cough and
yes,
sort of thing?
Okay, so yeah, GenWise up until the end of yesterday, and I haven't caught up on the numbers today, and sorry I haven't got a PowerPoint, you just have to listen to me and look at the lovely AMA sign. GenWise had done about 181 follow-ups up until the end of yesterday, and I've probably spoken to around 50 or more of those, so I've got a fairly good handle on the story. I have to say that all of the patients are incredibly appreciative of the call. Some of those calls are quicker than others. and some people have had a bit of a terrible time, and so it's an opportunity to debrief. So it's very much not just a physical wellbeing check, but a mental health check. But yes, so generally, on the whole, most patients are relatively well. We are contacting them fairly early in that illness process and identifying. We have, I think Danny was asking me before, and I know of 4 or 5 that we've had to send to hospital, but there's probably been a few more than that, but it's a fairly low incidence that we've identified over that call. And then generally they're quite well. The things they talk about initially was about the cough. It's surprising that not many of them have a documented fever at all. And that's contrary to what we were expecting. And more increasingly, people are talking about gastrointestinal symptoms as part of that picture, or just that's the only symptom. So that seems to have been a bit of a change in the week that I've been making those calls in the clinical profile. I don't know quite what that means. But yes, and so we talk to patients about the normal process of the illness, where they deteriorate often or can around day 7 to 10, to watch out for that. And we have, there were patients that were contacted, say Wednesday of last week, who were really well and minimal symptoms. And when I called back over the weekend, they had utilised that escalation plan that I put in place on the phone with them, and 2 of those had gone to hospital. So that's what we're hoping would happen, that people are identifying when they need to. So so that's sort of a bit of a snapshot.
And what do they think about cruise ships from now on?
Yeah, so I did have one couple, which was a bit of a, so they were on their honeymoon. Her first cruise, he loves them, she doesn't, and feels very strongly about that now. And she was, yes, very disappointed with how that all went down, from the experience on the ship and then how they managed them when they got off. And yeah, there's a lot of lessons to be learned from there. But I don't think the cruise ship industry is going to do well out of this. The toilet paper industry is, but not the cruise ship. Yeah. So yes.
And overall, the majority of them have been able to name a usual GP or a regular.
Absolutely. I think there's, I don't know, Danny, you'd know because they all come to you, but there's been a total of, you're saying 6 that haven't had a usual GP out of that, over 181. So I think that's really impressive, and that people had a usual GP, named their usual GP. And the other thing that I've been really impressed about is that the GPs, in the number of cases, had already made contact with those patients. They had either seen the positive result, or they'd been informed, and they'd done a tele consult with those patients, which was fantastic. And that's what we're asking them to do, is to follow those patients up with a daily phone call, even if that's over the weekend. And the GPs, I have to say, that I've spoken to have been fantastic at taking these patients on, and really keen to be involved and help. So thank you to our GP community.
Yep.
And I just thought I'd raise as well, because a number of people have posted on the Q&A how great this is, but also just want to get a bit of background about where we're at in terms of the LHNs managing patients, and then where does that fit with the GP assessment team. So I'll just give a little bit of background, and you can talk through that, Jenny, as well, that, this is only a new process that's come into effect. So we've got some GPs who are saying, I've been looking after my patient now for nearly 2 weeks. That was before that process had come into play. And so what we are finding is that we are still working through these issues around how patients are managed in the flow through in terms of community management. So we've got the different groups, so the RAF lenders, Lower Mac are doing different things at this stage. We're hoping to get everyone to work together so that all patients will run through the risk assessment process, which Jenny was just talking about. So there are patients who are not on that pathway. So it's only been patients that have been diagnosed recently have gone through that pathway. So that might be why some of you, as their regular GP, haven't heard from anyone from that team, or haven't had that verbal handover on the phone. But certainly Jenny's been doing a fabulous job at writing protocols, getting everyone to work together. You've got quite a new team as well, Jenny, there, and a number of GPs that you're working with as well. So and another question has been around coming out of that process, and in terms of how does that work. We've got a couple of GPs who are looking after patients where they're saying, you know, in 2 days' time that would be the end of their time. Can you talk a little bit about how that sort of works, or whether we want to talk to Louise about that? What are your thoughts, Jenny?
Happy. So I guess, well, I don't guess, I know that when we've handed the care over to the GPs who are very capable and competent, so they would then at that time, our involvement from the community assessment team is completed, and those GPs will take over the care. So then they would be looking to lift the quarantine, if you like, at that time. Now, there is a requirement of CDCB to get a clearance, as far as I understand, and they've actually been contacting patients at that point in time. And so we began discussions today about how we could, at GenWise, and I don't know what's happening at the other places that are doing the follow-up, will incorporate that template as part of our notification to the GPs, so that at the end of that time, the GPs will just have a link to send straight through. So we'll minimise calls and duplication. I have to say, some people, as much as they love to, who wouldn't want a phone call from me? But some people say, oh, I've had so many phone calls. So although I think it's really important, at the same time, we do need to be mindful that these people are not always feeling fabulous, and that we don't really want to ring them unnecessarily. But so that's another good way of how we can work together across the system.
So, I mean, I think it's a bit like Emily said, we've still not got this process streamlined, and we have been working on it for some time to try and get those people out of isolation when they're ready to be out of isolation, so that that person knows that they're cleared and can be released from isolation. So the guidelines are, it's basically when someone has at least 10 days have passed since the onset of symptoms, and they've had a resolution of their acute illness for the previous 72 hours. That's the criteria for patients in the community. So if you have someone who has been in hospital, there's different, for health reasons, there's different criteria. And also that criteria is only for community patients, but also it's not suitable for someone in an aged care facility or someone who's a healthcare or an aged care worker. If someone who's a healthcare or an aged care worker or is in an aged care facility, then they actually need to have the criteria a lot more strict, and it does include having repeat testing.
Mm-hmm. And we, as part of the patients that we are involved with, send out those guidelines to the GP with the clinical record as part of our email fax stream.
Yep.
We've certainly had a lot of questions while people are waiting in that time frame of waiting for a swab to come back. For instance, what does that mean for other members in the household? So say, for instance, you've got a family, the father's been tested, he's got symptoms, there's a young baby at home, a couple of other people in the household. Do those people who are close contacts to that person, do they need to self-isolate for that time while waiting for his swab to come back? Particularly if he is high risk, and it is thought perhaps that he could be a positive case.
So we wouldn't recommend someone to self-isolate, so for those household members to quarantine. If they do become unwell, we have that general recommendation that anyone who's unwell with a COVID-like illness should be isolating, and as in, staying at home. As in, if you're sick, don't go around and only seek healthcare if you need healthcare. Just that general recommendation. Same with anyone who's got gastro or something. We don't want people who aren't well potentially infecting others. But as far as actually a quarantine, so if you have a contact of a suspected case, is not required to be in quarantine.
And say, for instance, you do have that situation and the father does come back positive, and they're in the household, there's a wife, maybe 2 kids in there as well. Do those members of the family, obviously they've now been exposed to someone who's a positive contact and a close contact, do they need to be isolating at home for the same period of time as, or for a longer period of time than the husband who's been diagnosed with COVID?
So that's a little tricky, because it really depends on the household situation. So the isolation, the quarantine for the contacts is 14 days from the last exposure to that person whilst they're infectious. If they have a household such that they can safely separate in their household, then that period would start, that 14-day period would start from the moment they are appropriately separated in the home. But in a lot of houses, they won't be able to do that. And so then that 14-day period would start when that person is no longer, the index case is no longer infectious.
Wow.
But if you do have, a house such that you can have your own bathroom, they can be in a separate room, they can have meals brought to them, and they don't need to be sharing those common areas, then it would be from that the day that you realise that that person is positive. But in a lot of circumstances, people won't be able to do that.
No mothers will be able to, Louise.
It's all very challenging, isn't it, the logistics around this? And I guess something that has come through is around social supports that these patients need at times when they are at home and they are in that period of being isolated. And certainly this has been something that we've been asked about, what supports can you provide in terms of shopping and things like that. Jenny, you probably would have those conversations with people as well. Like, I don't know, how do you respond to that when the patient asks you about the supports that they need?
Yeah, so we have the SA Wellbeing team that we can actually refer them to for community supports. But Woolworths, there's ways around it. So getting delivery at home has been tricky, but Woolworths have been fantastic. They've got a form on their website that if you complete and say your reason is because you're COVID positive, then they will approve your home delivery and give you a login code. Sometimes it's busier than others, so it might take a few hours or you might not get that approval to the next day, but that's really something that's helpful for patients. But if that's not possible, the community team can organise dropping off of groceries. Also, if there's no family or friends, I think for a lot of people, number of people I've come across, which is slightly not what you're asking, but is the spouse, an elderly spouse, isolated when their husband, in these instances that I can think of, has been hospitalised, and so one's in a rural community and the other one was at home. She has a landline, no mobile, no internet, and she has an old-fashioned bank book that she goes and gets cash out and pays at the post office. So she was really struggling, and she didn't even have a way to know what the Royal Adelaide's phone number was, so she hadn't even been able to find out what's happened to her husband for 3 days since he went off in the ambulance. So that's something that the GP, well, in that instance it was me, could help with. But then I also referred through to the social work department at the RA where her husband is, and then they were able to take on a lot of that support. So there is supports out there. The community team can provide, also a phone call where they're chatting through, giving person opportunity just to debrief it as well. So yeah, I think there's lots of resources. It's about how we pull them all together and everybody working together for the benefit of that patient.
And one of the areas around this is certainly also relevant for both community care and also in the hospital setting as well, is around healthcare workers who may test positive. Now, we have had a few questions on this, and I'm sorry we haven't got to those questions. We did have ones around, are there any concerns around healthcare workers being potential contacts for people with COVID currently, and also around the process for healthcare workers in terms of returning to work and the repeat testing that's required at the end of that process. So I don't know if you could elaborate that on that area, Louise, around healthcare workers.
So, healthcare workers are always a concern in that you potentially can expose a lot of vulnerable people, and that is why we have that them listed as a group that we would test, even if you haven't met one of the other criteria. So if you are a healthcare worker and you have a fever or acute respiratory illness, you should be tested. You should stop working, get tested, stay in isolation until you have your test results. So that is one way of limiting the spread in healthcare, and that's really, really important. We don't want to infect people, and even if you get your results back and they're negative, you still shouldn't go back to work until you're well enough to be at work. Don't go to work if you've still got a fever, if you've still got an acute respiratory infection. Don't be at work.
Yeah. I took a day off last week. For the first time in 20 years, I had a cold and I didn't go to work.
Well done.
It felt good.
And just around the areas where we're talking about with healthcare workers, in terms of then the testing afterwards. So there seems to be, is there going to be, do you think, any change in that guideline? So currently there's the processes for testing of cure essentially. Do you expect any change in that at all, Louise, to happen?
I don't think so that will happen in the near future. We really want to be sure that our healthcare workers are not infectious when they go to work. And that's why we've kept it at that really quite strict criteria to make sure they're not infectious in the workplace.
Yeah.
No COVID positive healthcare workers to date in South Australia in the cases, or
Yeah, there have been.
there have been? No.
I've spoken to some.
Okay. Don't want to give away any names.
No, definitely not.
Okay.
And just in terms of community.
Sorry, I might go back to that. We don't believe they've acquired it in the health.
Oh, no, that's what I meant.
No.
Required.
Oh, no.
Overseas travel.
Thanks for clarifying that.
That's
Too many ski trips. Let's publish that. In terms of community management for country areas as well, Jenny, are we seeing that country GPs are embracing this process, or what's your experience been around patients who are not living in urban metropolitan Adelaide?
Yes, well, like always, our rural colleagues are very capable and have, stood up and in most instances have been the ones that have done the testing or organised it in the first place. So they're very aware and very happy to take on the care. I think the social isolation is more difficult for the patients in country areas, especially if they live alone and they're elderly. But the GPs have been putting in even calling a couple of times a day. So, I have to say the rural communities have managed it extremely well, as have the urban GPs that I've been involved with. So everyone's doing a good job.
Just briefly on the rural areas, we're going to be putting out a press release. For God's sakes, don't implore those people that normally have holiday homes at Victor or in the country or want to go on a grey nomad type trip. Do not do that. Don't be selfish, because at the moment our problems is the capacity is dropping in the various country centres, partly because they can't get certain doctors because they're interstate. They've had to close some because they're the combined aged care facility emergency type places, and then to take it down to Victor would be like a time bomb. So really, our problem is that this week is the week because school holidays comes in, and then suddenly everybody feels that they can go down. Please do not do that. This is really important.
And then Easter as well.
But actually, going back to that, we've had recommendations from our Prime Minister that you're really not meant to be. You're meant to be keeping your travels around to a minimum. Really meant to basically be going to work, doing your shopping, and a little bit of exercise, and that's it.
Medical appointments, I mentioned my holiday house at Goulburn. Louise quickly said that is not essential travel, and I'm not going.
I'm going to ask a couple of final questions just so we wrap up, because it's been an epic 90-minute webinar. And so thank you for all of you who have stayed and listened and who then sit through the recording. And then Danny will ask something as well. Just this is for you, Tom, around stool testing. So I've gone back to that topic again. So there was some advice given out. So one GP has posted there's been some advice given out to them because a patient had exposure to someone and was a close contact to a COVID positive patient, was having mainly gastrointestinal symptoms, and was advised by the lab that she should order a stool test PCR for COVID, but there were some concerns about whether that could be ordered or not from a GP in the community, rather than doing a nasal swab because her symptoms were predominantly gastrointestinal. So I just want to put that out there. Is that something that you think we should be thinking about in patients who are close contacts of a known positive case? And Louise, you might.
Well, in the first instance, certainly the oral nasal sample is the preferred sample. I mean, I suppose in certain circumstances it could be submitted, but we haven't been receiving those at that point. So Louise, I don't know if you've got any comments about that.
I agree. It's mainly a respiratory virus. So you take a respiratory specimen. But SA pathology, my understanding is, does have the capacity to do a stool test if that is the symptoms. But you would want to take a respiratory specimen because that's where you most likely get the bug.
Yeah, I mean, we have tested feces and detected virus in feces, but they've been in a controlled way in patients in hospitals to this point, and not as a screen.
I was just hoping to make a last comment about Jenny Gould and the team, and then all the GP care of these 180 plus patients in the community. There are some specialists in the hospitals who are aghast at what we're doing and think every single patient should be under an ID specialist or a respiratory specialist. Hence some specialists, when they find a positive, are latching onto that patient and keeping them, and that's fine. But as the numbers are just going to increase and increase, even, hopefully our curve is flattening, all right, but this is going to go on for weeks and weeks. I mean, I think we can manage these community patients. So this is a chance for general practice to step up and show that we're safe, competent doctors. We've got good safety netting, that when someone does get unwell, that day 7, day 10, viral pneumonia, that you get them to hospital. We don't want anyone falling through the cracks. So I'm especially worried about Easter, where you really do still, it's just a mobile phone and a quick check-in call. So let's show the rest of the health system that general practice is professional and capable. We're a damn lot better than they give us credit for, and I want to show them that general practice is a specialty in its own right. Thank you.
Well said.
Thanks, Danny, and what a great way to finish the webinar. So thank you so much for everyone who's come along tonight. It's just been so wonderful, the collaboration. Thank you to AMASA for hosting us, to Adelaide PHN for providing such a great platform and allowing us all to come together. The PHN has been working really hard to try and source PPE supplies, and really we're seeing some progress happening, which is great. I will just make one final comment before I close off, because it has been raised in the questions and we haven't quite got to it, was around the fever clinics and respiratory clinics and what do these clinics mean. So I will just finish on that. So these are different clinics. So respiratory clinics are designed for patients who have respiratory symptoms who may not meet the criteria for COVID testing. So those are the clinics which are federally funded, which the PHN is supporting in terms of helping them to become established, and we're hoping to see them online by the end of the week. The different clinics are the COVID clinics, which have also been referred to as fever clinics. We're trying to avoid that terminology. The COVID clinics, these are the clinics which are co-located in the main hospitals at the Lyell McEwen, the Royal Adelaide and Flinders. And each of those clinics are seeing patients who meet the current CDCB criteria. So I just wanted to talk about that just as a final statement, because we have had a few questions. The other thing as well, of course, is the clinics that SA Pathology has just been providing, which is fantastic, where the referral is given by the GP, whether that's by telehealth consultation, and then the patient then books in and attends for a swab. And it's been fantastic to see how quickly these clinics have got up and running, and Tom's been up in the Barossa today establishing the clinic up there. So we're so grateful for everyone working so quickly and so hard to get all of these things happening.
And then on top of that, there are some GP practices out there that put mine to shame. They've been planning 10 years for a pandemic. They've got PPE up to their eyeballs. I won't mention their names because people might raid them. They're doing their own drive-through clinics, their own swabbing. Because as Tom said, 50% of swabs are still coming from the community. When this is all over, we're going to have to re-look at this whole pandemic planning business. I think my practice, we had 20 PPE kits or something, and they were gone in a week. So anyway, that's for the future. But don't underestimate the number of GPs out there who've got the right equipment, doing it properly, and running either their own internal swabbing or their own drive-through clinics.
Yeah, so keep up the good work. Thank you so much. We're hoping to continue these webinars, and thank you for staying tuned for this period of time.
Thank you.
I'm just going to